Hello, I'm Paula Diane Cunningham, State Director for AARP Michigan, and I am so glad you are here with us today. This is the fifth event in our Ask the Doc virtual series. If you missed any of our earlier sessions, don't worry. You can catch all of them on the AARP Michigan virtual YouTube channel. We'll drop that link in the chat for you. This series has been absolutely phenomenal. It's brought clarity and expert insight, and also real conversation to the health issues that matter most as we age. We've covered everything from weight loss medications like Ozempic and the benefits of intermittent fasting to candid conversations about sex and aging. Again, you can watch those on our YouTube channel. We've talked about the emotional and physical toll of caregiving, and we've explored the medical science behind cannabis and healthcare. And today we're diving into one of the most important and personal topics of all, and that's dementia care. Dementia isn't just a medical diagnosis, it's something deeply personal, affecting lives, families, and communities in such profound ways. Approximately 1 in 9 Americans over the age of 65 is living with dementia. Well, those numbers only tell part of the story. Behind each statistic is a real person, a parent, a spouse, a grandparent, a friend, and someone that we love. And walking alongside them is often a caregiver, someone who may be overwhelmed, exhausted, and doing everything humanly possible to make certain that they help the loved one and that that person ages with dignity and with respect. Did you know that right here in Michigan, there are 1.73 million people who are caring for someone close to them? Those are unpaid caregivers. That's nearly 1 in 5 Michiganders, and many of them are navigating this journey without enough support. So today we're here to help offer guidance and hope. We're here focusing on positive and compassionate strategies for dementia care, ways to support both the person living with dementia and the caregiver walking beside them. And to lead this important conversation, I couldn't think of anyone better to be with us today than our own Dr. Michael Shafer, who is the Director of Neuropsychology and Co-Medical Director of Provider Wellbeing at University of Michigan Sparrow Hospital. He's also a clinical instructor at Michigan State University School of Medicine in the departments of rehab medicine, radiology, and neurology. And he has published numerous research studies and conducts national multi-day seminars strictly on dementia. In addition, Dr. Shafer and his wife started the Greater Lansing Care Foundation approximately 4 years ago to provide greater levels of support to caregivers living in the Greater Lansing area who have a loved one living with dementia. Dr. Shafer will start off with his insights on positive strategies for dementia care, and then we're turning it over to you, our audience. We've set aside most of our time today for your questions, so please drop them in the chat anytime, and we'll do our best to respond to as many of them as we possibly can. So, with that, it is indeed my privilege and our honor to welcome Dr. Michael Shafer. Hello, Michael. How are you today?
Hey, Paula, how are you?
I am great. I'm better now that you're here and that we can answer some questions for folks in just a few minutes. So I'm going to turn this program over to you so you can give us an opening and then we'll get to the questions. How's that sound?
Absolutely. It sounds fantastic. Let me just start off by saying I'm so thankful to you, Paula, and to the AARP for providing such an amazing platform for people to learn. Being a caregiver, in my opinion, is one of the most unbelievable opportunities that individuals can have, but there's a lot going on. So we're going to try to talk about that a little bit today. Okay.
Sounds good. Sounds good. Thank you.
Yeah, absolutely. When we think about the people, I wanted to just dovetail off of something that Paula said, which is to think about 1 in 9 or to think about 1 million people just in the state of Michigan. If we were to step back for a second, we know for sure that in the United States, by the year 2050, about a third of this country is going to be around 65 years or older. So we know we're aging, and we know the number of individuals who are going to be experiencing some sort of neurocognitive change is also concurrently going to go up. So the speculation is that the 7 million people that are now diagnosed with dementia in the United States or Alzheimer's disease is probably going to almost double by the year 2050. And who is going to help them? The institutions, the medical facilities, a little bit, but it's family, it's individuals like yourselves. And if we were in the same room, I always start off these lectures by just sort of trying to get a quick raise of hand, like who here has a loved one with dementia or knows somebody with dementia. It's a little challenging online to do, but I suspect it's a large number of you. So I thought maybe what we could do today is just start off the conversation thinking about compassionate ways to help our family members. And so I thought what I would do is maybe just give some ideas, some thoughts, some practical ideas, and also maybe some global concepts. So one of the things that I think about first and foremost, and I think it's real applicable and essential to say, is that everyone here has, for those of us that have a loved one, they're all at a different spot. And so anything that I say today is not going to be just generalized to everyone. And I think it's real important to remember that. I'm going to give some general information, some general thoughts. But the idea that somebody who is experiencing some mild cognitive impairment, which is a precursor in some cases to dementias like Alzheimer's disease, that to think that that individual is going to have the same thinking difficulties or the same emotional experiences as somebody who is severe, who has severe dementia, that's not reasonable. And so I'm going to give some general ideas, but please try to keep that in mind. Also, I think this is really important to remind families. I try to do this every time I see somebody. There's no real right or wrong way to do anything. I actually think that if we're invested and we love somebody, that's the best we can do. Now, I'm going to try to give some advice and some ideas, and you certainly can ask me questions about how do we go about doing this. Take away dad's keys or whatever it might be. But I just think that there's no right or wrong answers, and it's really important to remember that. So again, not everybody's on that same path. Not everyone's in the same spot, and there's really no right or wrong answers. And I think if we can remember that, and also I want us to, to think about the reality is there's also lots of cultural differences that individuals may be experiencing. So one family's cultural experience may be quite different. And how does one with a specific cultural background that doesn't really utilize medical facilities as an example, is more reliant on in-home help from family, how is that maybe different? So we'll try to talk a little bit about those things. Again, just trying to keep in mind, things are general. I'll do my best. When I think about compassionate help, right, I think about caregivers. And so I want to think about two things, and I'll try to interweave them in this conversation somewhat quickly. But two thoughts for me is that there's these two areas of focus, and one should be the caregiver themselves. I think that making sure caregivers take care of themselves is essential. I know it almost sounds like obvious to say, but without a caregiver being in the healthiest spot that they can be, how could they possibly take care or maximize the care they're providing? So taking care of it. So I'll comment a little bit about that. And then also just trying to think about the individual who is living with dementia. One of the things I want to think about is trying to provide treatments and management and compassionate care from a patient-focused perspective. So thinking about what is this person like? So I love golf as an example. So if providing me support, trying to associate maybe some things that are golf related or whatever to jog my memory, to help me be more present in the moment, to participate in communication. From families that I interact with, I hear lots of questions like, well, how can we help facilitate communication? How can we make that process better? How can we get it so dad doesn't just sit in the corner, or that mom isn't, just sitting in the corner? Again, we want to maximize their lives. The reality of the world is, again, with different stagings, we want to encourage the maximum experience in life. And so I think if we try to come from a caregiver perspective, if we try to a patient's perspective, if we try to remind ourselves, compassionate care starts at home, taking care of ourselves. I think that's an important starting point. But regardless, again, I want to talk about just establishing strong support networks. I think this is super critical. So two kinds of support networks that I think are unbelievably valuable. One of them is going to be the medical support. Making sure, as an example, that you have an excellent primary care physician is a really important thing, and that you communicate with them. In the hospital, it's surprising to me how frequently someone will say, well, we haven't really talked to our primary care about our concerns. But just thinking as we age, the likelihood of having medical comorbidities goes up. So urinary tract infections or dehydration seem to be the two most common things we see in the emergency department for older individuals. And they can make dementias look, they can exacerbate them or make them look worse. And so just making sure we have a good dialogue with our primary care is really great. And then again, if we're worried about dementias, having an excellent neurological pathway for us is super important. Again, if we're thinking just about like efforts and aiming and trying to make people's lives better, what are some ideas that I think in the little bit of time we have, what do I think we should make sure we're really good at? Well, one of the things that we can do is that we can talk about how to de-escalate people when they get agitated. Okay, how can we do this in a really effective way? Again, not everything works the same for everyone, but thinking about things like relying on calming music. I tell families all the time, why argue with someone? So I want to encourage us, let's not be argumentative or correct people. Correcting, there's no real reason for it. Our goal is to de-escalate, it's to facilitate excellent communication. Creating activities, meaningful activities, instead of just sitting in the TV, engaging the individual, saying, well, what can I do here? Avoiding overstimulation in an environment is really important, because when brains get overwhelmed, unfortunately, they start to react. And when our frontal lobe and prefrontal lobe systems aren't helping us keep things in check, we can have acting out and so on. Thinking about also when communicating and feeling about somebody's agitated, super important to just check in on their basic needs. Are they in pain? Are they incontinent? Do they need to use a restroom? Are they hungry? And sometimes just managing these simple basic things and making sure we're in tune with them can actually reduce and improve behavior, reduce agitation. Again, if you're thinking about the individuals who have just been diagnosed with dementia or they're starting to be suspicious of it, for those individuals, we might just want to, as a partner, we might just want to say, I hear you. I want to acknowledge that, because it's very scary, not just for the person who's been diagnosed with dementia, but for family members when we don't know what will happen. So again, just trying to think about like, how do we maximize that journey? And communication can be really central to those efforts. If we're going to try to think about, again, improving communication a little bit, one of those suggestions I would have is that we keep things very short and concrete. The longer we go on with our sentences, or even the larger those words are, the more difficult it is to follow. People with dementias will very clearly say, as you're going on, I'm only remembering the first part of it. And so the more we put on there, the more the burden that brain, the less likely you are to have an excellent communication. So let's not do that. Maintaining eye contact is really critical. Avoid, again, correcting and arguing with people. And then I like visual cues, things that are going to reinforce the verbal things that I'm doing, so that the person is getting multiple modes of communication, that they're understanding what I'm saying through multiple modes. Also, just thinking about like if somebody, when we're communicating and we're doing our best, but what if they don't want to do what we're telling them to do, if we're not encouraging them? So I have a couple ideas there. First and foremost, along the ideas of not arguing, I want us to stay calm. If we have to, what about reframing the task? They're adamant they don't want to do this. Is it possible if we reframed it, we might get them to do it? So just reframing something could be very helpful. Sometimes just trying it later, coming back later, reapproaching it, trying to reset the situation can be very effective. And then again, thinking about people with mild cognitive impairments, again, acknowledging that frustration and that fear, and maybe just asking the question differently, how do you think that we can do this? And relying on them, preserving their autonomy, hoping to maximize their own sense. One of the things I hear a ton about is like, well, what do I do how can I remain a good communicator if I'm dealing with things like sundowning? And again, not everybody with neurodegenerative diseases is going to exhibit sundowning, but many people will. And it's a biological process. So there's a couple of things that we can do to try to reduce those negative effects from sundowning. One of the things we can do is try to keep a regular routine. And in fact, brains that are experiencing neurodegenerative disruption really love routine. So making sure things are pretty consistent can be quite helpful. Offering people, again, with mild cognitive impairment, like offer them reassurance, right? When sundowning is occurring and I'm feeling more confused, reassuring the people, reorienting them to some extent. Again, maintaining and keeping routines at night is also quite important in terms of reducing the negative effects of sundowning. And then just thinking about the basics of making sure that the rooms are sort of really well lit. I think for most of us, we hear about psychopharmacological interventions as an example to help manage, and I think of that as an extension of communication in a way. But how do we help keep people off of medications? How can we develop behavioral strategies that will help our loved ones? And then also reducing the burden that as a caregiver I'm experiencing. And so the last thought I have before we open it up to all the questions is just, as a caregiver, you really have to be mindful to take care of yourself. It's so important. My wife and I started a foundation specifically aimed at caregivers for this reason. We know the data on caregivers who have a loved one living with dementia suggests that they experience higher rates of depression than other same-aged individuals. We know they don't exercise. We know they don't go to the primary care physician as frequently. So they, in effect, are more likely to neglect themselves. And so I want to remind us all that as caregivers, we have to invest in ourselves too. It is not easy. Identifying and utilizing resources to the best of our ability through AARP, through foundations like my own, to receive respite or to participate, all super important if we're going to work on developing compassionate ways to interact with the people that we love so much who are living with dementia.
I absolutely appreciate all of that. It's very, very helpful. Sometimes we think it's much more complicated than it really needs to be. So you've given us some real practical, day-to-day, simple things that we can do, and taking care of ourselves should be at the top of the list. We have a whole lot of questions, and we want to get to as many of them as possible. And again, just put your question in the chat. Dawn wants to know, how are we supposed to figure out what her mother wants when she repeatedly says she doesn't know? I don't know, when it comes to doing something like standing up, even though Dawn is showing or demonstrating how you stand up from the wheelchair, her mom keeps saying, I don't know how to do this. I don't know how to do this. What tips would you give her?
Boy, that's a tough one. I think that our goal, just in medicine specifically, I think about myself and how do we interact with patients? The goal is to try to identify what it is you're trying to achieve. So if mom wants to get up, okay, and somehow we're getting that, how can we achieve that in a very safe way? But this is a really great question. I mean, how do you know what someone who is having a hard time communicating with you wants? And so a lot of it is knowing the people in general and looking for cues and looking for things that will help, if you think they're agitated, decrease that agitation. I don't think there's any one way, though, that just specifically we do this and we get there. I think that's, by the way, the real challenge with dementia versus, let's say, cardiovascular health or something of this nature, is that for everyone, there just isn't the same answer. There isn't just the same response.
Absolutely. Roxanne would like to know, could a diet heavy in sugar cause dementia?
Yeah, I don't think the general sense is that sugar in general is causing dementia. But what I will say, and what I would advocate for sure, and certainly part of my 2-day lecture on Alzheimer's and dementias, includes discussions about eating well. And I think that if you were to read the literature on living well and living long, so not just living long for the purposes of living long, but rather to say, I really want to live well and I want to live long. There's a really great book by Dr. Peter Attia called Outlive. And he talks about this at length. There's really probably 3 areas. So just to dovetail off of this for a second, making sure that our nutritional intake is really where it should be is central. Improving and making sure that our sleep is where it should be is really important. And then exercising. So to this question specifically, though, if we think about one medical comorbidity that we 100% want to make sure that we avoid as it relates to our efforts to stave off dementia, I think you're going to find that disease being diabetes. And if we think about blood sugar dysregulations and we think about how blood sugar goes up and down based on what we're eating, we know for a fact that our goal with blood sugar levels is to keep them super stable. And so eating things that are going to fluctuate blood sugar is no good. And we know that the reality of the world is that if we look at dementias, even when we consider the fact that genetics make you more likely than not as a first generation person to develop a dementia, it doesn't mean that you're going to. And in fact, if the literature is accurate, probably 75% of all dementias are modifiable. So if just because my mom has Alzheimer's disease doesn't mean that I'm going to, and there's studies on this that demonstrate this consistently. So if there are modifiable things like eating sugar, okay, if I reduce that. And so I think bigger question is, how do I stop eating processed foods? How can I take on eating cleaner proteins? How can I reduce fluctuations and variability in my blood glucose levels? So I don't think it's as easy as just saying, hey, sugar causes dementia, but the reality is diabetes influences inflammation in a body, and inflammation we know for sure is bad for brains.
And we know sugar can impact other things, even though it may not be dementia. So a good
100%.
balanced diet is.
Yeah. And by the way, I think that's a really great point. And by the way, if we were to think about just in part because we get hyperfixated on Alzheimer's disease, but let's talk about growing numbers of dementia cases that are vascular based. And there, I think, is where the conversation about blood sugar levels and about exercising and making sure our cardiovascular health is optimized is really relevant. So again, I think it's relevant for Alzheimer's disease, but if we're thinking about the growing numbers of people that are having a vascular-based dementia process, health, and specifically the reduction in sugars is really smart. It's a good question.
And I think you've answered this other question already, but you may want to just have another footnote. Marie wants to know, her grandmother had Alzheimer's and but she, as everyone knows, is a form of dementia. Is there a chance that she will also inherit the disease? Or she's been told that sometimes it skips a generation, but I think you just sort of touched on that. Anything else?
Yeah. Again, I think the literature in this area is pretty well established that just because you have a first generation person who has dementia. So if you look at the data, again, I'm sure I'm pretty close to right on this. I think the likelihood of having Alzheimer's disease or dementia, if your mother or father had that, is probably around 12 times more likely than, let's say, the general population. But having said that, again, there's a vast majority of people who have a family member who don't have that have dementia, and they themselves do not develop dementia. And so I think it's a lot about making sure that we maximize our own health. So somebody even down in here says, well, what about doing the test for APOE4 alleles? Okay, so I'll just skip ahead there. And what does the data on the APOE4 allele say? Well, even individuals, there's data to say just because you have the APOE4 allele, and these are these two chromosomes that you're going to get, you need the people who are most at risk for Alzheimer's disease, again, put into a silo of more likely to develop, are going to have both of those alleles. So one of the chromosomes from mom, one from dad, they come together versus, let's say, an APOE4 and a 3, or a 3 and a 3. And surprisingly, a 2 and a 2 is a protective factor for some reason. But the APOE4 allele, just because you have it, does not mean you'll have Alzheimer's disease. Same is true for identifying amyloid beta in your body, which there are tests that do that. So I think that the tests they're okay to do. I just don't think that they are the end all be all, because you see that, you know you're going to have it.
And once you start worrying about it, you actually do more damage than if you just go ahead and live your life and do the things you're supposed to, right?
I think that there's some sense of that, and I get a sense that some of that's accurate. You know, just recently there's this TV show somewhere, Hulu, and Chris Helmsworth, the guy who plays Thor, I think, he does this show where it just talks about maximizing himself as a human, his own reducing anxieties, taking his physical strength. And we already know him as being so physically impressive. And one of the things they did was a study on him. They found out he had 2 APOE4 alleles. And so here now we know that this really remarkable human, this physically fit human, now has to think about that.
Right.
But will he get that disease or not? I don't know. And it's not as just slam dunk as one might think.
Yeah, and a lot of that's personal preference. Do you want to know or do you not want to know, but still continue to live your best life?
I think knowing, I just think knowing can be helpful. But again, I wouldn't want anyone to think, oh, because I have this, that's it.
Good point. Good clarification. Absolutely. Nancy wants to know, no, I'm sorry, and Miss George, when do you need to see a doctor? How do you know when it's time to go talk to a doctor?
Yeah, so I think that's an excellent question. You know, when you think about yourself, you think, wait a minute, I've been having greater difficulty. When you see people in the earliest stages of neurodegenerative disease, some features are fairly consistent. Often they will report, boy, I'm not remembering the right word. I look at that cup and I'm like, the thing with the water in it. You're like, right, what is that? Like, oh, I can't think of it. And for some reason that eludes us. And that seems to be a memory-based piece. And then our short-term memory seems to be going. And again, it may be quite subtle. The other thing to remember is that people who have cognitive reserves that existed before that were very high might look quite different than somebody who has lower cognitive reserves. So an individual who may never have finished the 3rd grade, never learned to read, might in fact be more at risk than someone who is a neurosurgeon, as an example. So for each of these questions, and I started off by saying this, there are so many vantage points to think about, thinking about answering them and about how we go about them. But I think that if you notice difficulties with your memory, if you notice maybe I'm forgetting a few things, and then importantly, other people are starting to notice it, I think a conversation with your primary care physician about this is really important.
It's very helpful. Susan wants to know, am I in the very beginning stages of cognitive decline? Should I see a neurologist or should I just go to my primary physician?
I think that threefold. One, I think that what you do, I think a good plan is to talk to the family physician, to notice, to have a conversation. Have you noticed this? These are my concerns. The family physician can run all the appropriate labs. Just for example, is your thyroid okay? If your thyroid were off, you could have troubles. Are your thiamine levels, are your B1, is your B12 okay? Do I drink? Should I stop that? Is there something else going on? Is my, is my blood pressure too high? Is there something going on medically? So I think first hurdle is to get with that person in a very open way. And then I think the second thing is to, if we've run all those tests and we haven't found low-hanging fruit that might have been causing this disruption, and by the way, sleep, when we're not sleeping correctly, as we age, what is one of the number one features? Well, I don't remember things very well. And if I'm depressed, if I'm anxious or I'm depressed, there's such an influence on individuals and their thinking from psychopathologies like depression, anxiety, that they in fact call it pseudo-dementia. The idea that I thought I had dementia, I was that depressed and my brain wasn't working. So making sure that all those things we've checked that off, we've looked at that. Okay, no. Now, what should I do? Well, in concert with that primary care physician, I think then you ask, can we do some neuropsychological testing? Can I do a cognitive battery and look, compared to other people my age and my educational level, am I where I should be? Am I better than where I should be? Or in fact, am I not doing well? And the testing there is very useful because it can show you. In many cases, I test people who are telling me, right, we're all sort of the worst judge of ourselves. So we're the worst, our own worst critics. And so I test them and everything is spot on where it should be. And they're like, wow, I guess there isn't anything wrong with me. And then strangely enough, I see them in 6 months and they're like, it all went away. Well, dementia doesn't go away. So,
right.
So being mindful and getting the examination that can look into these different cognitive domains. And importantly, dementia as a diagnosis requires a disruption of your memory, but it also requires another domain to be impaired. or to see some disruptions. I think the other thing is, if we're going to go get that testing, it might tell us, look, there are enough areas of disruption that we might call this a mild cognitive impairment, and we should be mindful about what we do there. Medication for Alzheimer's disease, again, efficacy of it notwithstanding, tends to be, seems to be some sense that using it earlier is better than later. So again, I think that that's where that test data, now we get this data back and we say, boy, we really are seeing some deficits here that are deviations from where we would expect ourselves to be, given our prior history, our prior employment, our prior academics, whatever. Then we say, well, I think we should go to an expert in neurology who can order some additional tests, maybe something like a CT scan just to rule out a quick scan for, let's say, a stroke. Maybe an MRI to look a little bit more in depth at the structures and to look for vascular disease, and maybe even a PET scan, an FDG PET scan, to look for metabolic uptake consistent with, let's say, a neurodegenerative disease.
Great.
If you have that plan of family doctor, if we need it, neuropsych testing, and if we need it, neurology is a strong pathway for someone.
Great, thank you. Keep the questions coming. There's a question from Nancy. She has a loved one in a memory care unit. How do you know that that person's being taken care of the way that they should? They're not telling you. So how do you really know? She's there every day. So how do you know that they take care of?
I think this is a really great question, Nancy. How do you know what you know? So I think what you do is you rely on experts. You rely on good referral sources. So I on our board for the Greater Lansing Care Foundation, we have an individual whose entire career is about helping people find these types of resources. And she's an expert in this. And somebody like that can say, well, I know this. I've recently heard about this. Let's avoid that. Let's be here. So I think my point of that is to say that when we're picking, being mindful about the facility and what we're hearing. Now, sometimes the truth is we're maybe a little stuck because the finances or how much we can afford mandates that we go here. Mm-hmm. But assuming all things equal, just for a second, picking a place for me, looking at things like, do you have a general facility? Do you have a rehab facility? And then if needed, do you have a progression where there may be a memory care unit where everything looks the same and has the same sense? All of that aimed at reducing confusion for this individual, the person I love the most. But having said that, if you have already picked a place and now you're just wondering, I think what you do is you go when they're not expecting you. Mm-hmm. I think you show up. And when you have somebody say, well, you can't do this or that right now, I would say, that's not right. No way.
It's a warning sign.
Yeah, that is an enormous red flag to me. Like, you should be able to stop by at any time. You should be able to have questions. You should also ask caregivers in those moments, let's say technicians or whomever it might be, what did they do here, here, and here? And if they know this person, if they're caring for this person, they're going to have the answers.
Right.
Right?
Right.
And so I think that's how you do it. I think you have the boots on the ground.
Rachel would like to know, she said her mom watches television all day and she's trying to get her to do crossword puzzles, listen to music, get off of the TV. Yeah. And she used to do that. So what kind of advice would you give her from getting away from the TV and trying some other activities to stimulate her brain?
Yeah, I can understand the motivation, but I would ask, Rachel, why? Why is it you want to do that? What is your goal? What are you trying to accomplish? If you were going to tell me that listening to the music, doing the crosswords would somehow make the brain better, I would say, great, then we should do that. But if that's not going to happen, and what you are going to do is potentially risk increased agitation or higher levels of confusion, then I wouldn't do it. Having said that, I think there is some evidence out there that doing novel tasks is actually pretty good for brains. So even, by the way, socializing, there's data out there to show us that socializing for 1 hour a week in a novel environment can actually help brains substantially. So just some sort of support group, a group where they're playing, mahjong or whatever it is they're doing, can be quite helpful for people. But I would just say, to Rachel, what's your motivation there, right? Why do you want her to do crossword puzzles? And if it's because you think that there's a gain there, then okay. But, at the end of the day, also try to remember this. Put yourself, remember I was talking about this before, patient-focused care. If doing the crossword puzzle is going to remind the person that they don't remember as many words, which we know is an inherent piece of dementia, then we're probably putting them in a position not to be successful. And I don't love that per se.
That's, excellent advice. Jacob, he's looking for guidance to make a smooth placement of a patient with 6 to 7 years of dementia from home to a memory care facility. And there is strong objection to doing that. That sounds like it's a challenge, but I'm sure you have some guidance for Jacob.
Yeah, again, I think that this is a really common question that I hear. One, I hear a ton, how do we know when it's time to go? So maybe we step back for just a fraction of a second and we think about that. When do you know? Let's step back further. I told you there were no right or wrong ways to think about things. There's no just absolutes in this kind of thing. So I think if we're doing our best, we look at red flags. Are they wandering more? Are they more acutely confused? Are they doing things, behaviors in such a way that their likelihood of being injured is now going up? Are you no longer able to supervise them in a safe manner? Are they doing stuff like leaving the stove on? If we're seeing more and more of that, the suspicion then is that it's probably a good time to be thinking about a more structured environment. Again, what's the outcome? So as I was saying to Rachel, why? What's your motivation? So to me, motivation to be in a facility is for increased safety and the preservation of my loved one's health. So now here we are with Jacob's question saying, well, wait a second, what about if we have a person and we sort of think this is the right path and we're getting all this pushback? Well, depends on who you're getting the pushback from, by the way. So if you're getting pushback from the person who is being encouraged to go there, I think, again, there's no just easy way to do this. I think taking tours, I think reintroducing them to it over a period of time, if that's possible, is a good idea. Encouraging an opportunity to go during social events where they know someone and they're like, oh man, wasn't that fun playing euchre with Bob? And that person's like, yeah, that was pretty fun. But you have to remember, at the end of the day, even individuals who are experiencing neurodegenerative changes really want to retain their autonomy. For many people, they've been, 70, 80 years old. They live their whole life being super independent. And now what you're doing is saying, I'm going to have to go to a place where all people do, the only outcome there is pass away. And even individuals who are having difficulties with memory can appreciate that. So what I would say is we try lots of behavioral strategies, again, taking them there, lots of positives, having emotional experience, an affective one, because you can tell people things all day long, but if you don't help them emotionally understand something, it's just more challenging for sure.
I've heard over and over again from caregivers that they've had to almost reprogram their way of thinking about that individual. So so used to them doing certain things a certain way, and you have to rethink how the caregiver has to rethink their role in their life. So it's a major change for them as well.
No, for sure. And I also think that it's about just looking at the thing from their lens. Why is it that you're so adamant you don't want this? Now, so you can do a little snooping and say, well, wait a minute. My mom's mom went to a facility and she died. Well, of course that person is going to relate that, right? They're going to say, well, this is what happens here. So just trying to figure out, well, what is it you're afraid of? Well, I'm afraid no one will know me. Okay, well, if that's what you're actually afraid of, then let's find out. Let's go there and recognize, wait a minute, everyone here is wearing a name tag. Hey, guess what, Dad? They're going to check on you this many times. This is who this person is that you should meet. Again, finding out what anxiety they have or what it is that's worrying them can actually reduce all of that and make it so they're more amenable to going.
Michael, you've talked about this, Dr. Shafer, you've talked about this, but what are some of the tests, or are there tests, and Anita wants to know, that they can be done at home to know whether or not it's time to request care or to request further observation?
What, I'm not sure I know what observation means. What does that mean?
Well,
I
well,
guess.
that let's say, like someone goes downstairs and they forget what they went downstairs for. What are some of the tests? Is there something that you can do at home? I think that's what Anita's asking. That
Yeah,
lets you know it's time to get more a different opinion.
yeah. Again, I would just encourage people, start with the primary care physician, start with somebody who's done this before, and then go. I wouldn't do something at home and try to screen for it, just as I wouldn't be on WebMD trying to talk about, I wouldn't type in I have fatigue and then try to figure out why am I not feeling so good.
Oh, shucks.
And then next thing you know, yeah, I'm worried about cancer all night. So
Yeah.
again, I think we work with the professionals, work with people. I think there are plenty of things online that'll talk about screening, but first of all, when you get something wrong or you've misinterpreted, all of a sudden you're in a different pathway. So I think working with experts makes the most sense.
And this is a question of something that I know both Sparrow and McLaren have dealt with, trying to find a neurologist. How can someone facilitate finding a neurologist?
Yeah. So I think if you're living locally, you're right. I think that's a real challenge. Just like seeing any other specialist is a challenge. If I had an outpatient clinic, it's probably going to take 4 to 5 months to see me. If you're a neurologist, it's probably the same. So again, I think talking to other resources, friends and family, who have you worked with? Who have you felt like did an excellent job? For me, the most important thing in medicine is patient experience and family experience. Do you have an ability to identify someone who has excellent care reputation? And here at MSU, we have a number of physicians who are fantastic. And at Owasso, also, we have excellent physicians up there. In fact, I think in Owasso, in the Department of Neurology, despite it being a very small community, they have 13 neurologists. Mm-hmm. And it grew, when I started my training, it grew from one, Dr. Angela Borders Robinson, who was amazing. It grew from her practice to 13, and now they have an institute of whatever it's called up there, but it's excellent. So I think that there are ways to do it. I like to talk to people, find out who has had a good experience.
Excellent. We've got just a few minutes left. Mm-hmm. Let's take this question from C. Hoffman. Are there stages of dementia?
Mm-hmm. Yeah, so that's a really great question too. It just depends on what kind of research model you look at, or from whom, are you getting these different perceptions on staging. But I think a good way to think about it is that if you really want to understand the continuum of Alzheimer's disease, as an example, you think about it as there's a period where nothing's going on and you cannot see it. Let's call it fancy. Let's call it prodromal. It's before this ever becomes a thing. And by the way, there's a lot of research now to say that there probably is this breakdown, these protein dysregulations that are occurring are probably starting when we're 40. Maybe they're way, way before we even start to see the clinical symptoms of it. So let's just say there's a stage and it's a pre-problem stage. Let's just call it that. And then I think there's this second stage, which is there's a little bit of problem. There's a mild problem, and that stage is probably quite long. That might be kind of an 8-year stage, let's say. But it's that period where I'm starting to experience a little bit more disruption. And by the way, statistics and data and research will tell us just because I'm in that stage doesn't mean that I will for sure go to the second or third stages of actually having dementia or Alzheimer's disease. But it's an uncomfortable stage where I'm noticing changes, whether it's memory or something else. So let's just call that kind of a beginning stage. I think there's a middle stage where really things are becoming substantial. They're becoming more apparent cognitively, but also what we're starting to see in that stage is a decrease in our ability to complete activities of daily living. So now the stuff that I used to do independently for myself, well, now I'm having a little bit more trouble, or in fact, I'm neglecting it. And then we think about maybe that last stage where we're really significantly impaired. We are dependent on someone else for almost everything. I think if we keep it to those 4, it gives us a very good sense of it. There are other staging models. There are more stages and more complex, but I don't think we really need that. I think.
And thank you so much, Dr. Shafer. And we are out of time, but I do want to just take a minute and have you respond to Chris's question. He sounds like he needs some help. He says his mom has dementia. She has extreme sleep deficit. She takes medication, no longer works, but she's also severe anxiety, constantly overly thinking and obsessing, and takes medicine for that, but it
Yeah.
doesn't work. They don't know what to do to help her.
Yeah.
Well, can we get a real quick response?
Yeah, for sure. I think the short answer there is that, one, you're not alone, Chris. I think this happens to a lot of families. They start to see as the disease process progresses, it becomes more difficult, and sleep is one of the things that gets dysregulated. But I would say a geropsychiatrist, I would say reaching out to behavioral health at St. Lawrence as an example, working with a psychiatrist who specializes in older adults is the best pathway.
Thank you so much, Dr. Shafer. I'm sure everyone in the chat also thanks you for all this excellent information and wisdom and just the years of practice that you're sharing with us so freely today. We appreciate that. And for those of you who called in, there's a tremendous amount of resources in the ARP. If you go to ARP's website, and that website's in the chat as well, please check out the resources that are available. We want to make certain we connect you, the caregiver, with the kind of resources that you need. And stay tuned, because there's going to be some more exciting news coming in the next month or two between Dr. Shafer and his foundation, the AARP, and we're excited about that. So stay tuned for more information. Thank you, Dr. Shafer. We appreciate all that you do, and we really I particularly appreciate you dedicating your life's work to making certain that folks have a kind of life with dementia, with Alzheimer's, the kind of life that they deserve as they age, and age with dignity and with respect. Appreciate that. Thank you. Thanks for watching.